Yeah, I think it's a scientific question. I think the jury's still out to some extent, but in general, I hope that we can understand how to design policies and payment systems that incentivize all kinds of providers, doctors, nurses, hospitals, to improve the quality of care in ways that are meaningful to patients. So clearly things like reducing mortality rates, that would be a clear win, but also really thinking deeply about how to integrate patient-reported outcomes into data sources that are useful. I mean, the problem is anytime you change compensation or adjust a payment for hospitals or for physicians, you're using administrative data, and there's limitations to the use of that data. It's just a billing code doesn't really encapsulate what's happening with a patient. Patient-reported outcomes are a much more promising way to do it, but those aren't routinely collected in everyday practice. So we're far from an ideal learning healthcare system. I think that a lot of the discussion around hospital readmission reduction program, a lot of these debates are important first steps. The science of understanding how to design policies and payment systems in ways that provide optimal responses from providers in ways that are meaningful to patients is a relatively early science. And I think that it's important that we discuss these early lessons and push ahead. Yeah, we're very interested in understanding how to get outside of the traditional doctor's office visit. There are many ways in which the traditional doctor's office visit in the office with a physical exam are good ways to deliver care, but there are lots of other ways to deliver care, and I think that we've probably underutilized those areas. We have active, robust programs in telehealth, so video conferencing with patients instead of having them come into the office, and we really have had a huge growth in electronic consultation. So we'll be talking more about that at the Health Tech Summit later this afternoon. We are doing about 10% of all cardiology consults as electronic consults now. So when a primary care doctor has a question about cardiology, in about 10% of cases, there's an exchange of information and documentation in the chart, and we share the information with the patient without the patient having to go to the doctor. So we never push patients to do this, and we ask patients if they want this, and of course it has to be a clinically appropriate question. There's some questions that you have to actually go see the cardiologist, but we want to offer patients the opportunity to receive care in the setting that they want in ways that are safe, and understanding how to sort of break this Gordian knot of doctors and hospitals doing things simply because they're compensated to do them rather than not compensated, and understanding how to optimally provide care in ways that genuinely patients want to receive the care and are effective to give that care. There's a lot of problems with the specialist PCP interface nationally. It's very hard to get in with the doctor. Doctors' appointments in general are not when people want to go to the doctor. I'm a parent of young children, and so the doctor, we have to bring our children to the doctor. It's often 3 o'clock on a Tuesday. It's a horribly inconvenient time for parents. So in some cases it's important because that's a vaccine or something that you have to get in person, but not every clinical question requires the patient to come in for a physical exam and history from a cardiologist. It's not consistent with our clinical best practices.